and welcome back to the Advancing Healthcare Innovation Show. And I'm your host, Michael Stamatinos. Great to see everyone. Great to have you back here. And if you're new to us, we're super excited because we're really passionate about having exciting conversations with real leaders within our space that are painstakingly shaping the future of healthcare. And we're really passionate about leadership, access, innovation, adoption. And if it's your first time tuning in, let me just try to take a quick step back and tell you what we're doing here. So we are focused on bringing stories of innovation within healthcare to life. Our aim is actually talking to real folks that have been in the trenches, that are doing stuff, that are being proactive, and giving them the opportunity to share their stories with our community and ultimately with the world. And if you haven't done so before, make sure that you hit the subscribe button now, wherever you're at, so that you get new episodes that come right into your inbox. We've got an incredibly action-packed year with some amazing, amazing guests that are coming onto the show. And as you know, our field is consistently evolving. It's changing. A lot of things that are happening, especially in leadership. And it's important to have leaders that are envisioning the future differently and eagerly embracing innovation, and as well as addressing pressing issues and challenges and moving forward. So the guest on today's show is actually one of these leaders. It's my pleasure to introduce a very distinguished professional with an illustrious 30-plus year career that bridges healthcare, health systems, and health IT, David Bradshaw. So for 20 years, David served as the CIO at Memorial Hermann in Houston, where his leadership extended to a dual role as Chief Marketing Officer for 14 of those years, and he ascended to become the Executive Vice President and Chief Strategy Officer, where he was pivotal in strategy, marketing, information systems, business development, and the construction of the Population Health Services Organization, amongst other responsibilities. So David, his role ventured into a role that really leveraged a lot of experience, and he's now moved into as a managing partner at Waypoint Healthcare Solutions, where he's really channeled his extensive background to empower health organizations, driving them toward unparalleled success. And we're going to talk today around a lot of that experience, sharing his knowledge with us, insights that's really only attainable through doing. And we're going to talk a little bit about what he calls care orchestration and what that means in terms of innovation and leadership development. So David, great to have you on the show. Great to see you. How are you?
All right, Michael. Hey, thanks, man. Back from 2 weeks in Colorado. Loved it. Cool temperatures, low humidity. I live in Houston still, and the summers are brutal in Texas, but
I hear you. I hear you. So let's talk a little bit about innovation. So you've had an incredible, I'll just say, tour of duty throughout
yeah.
what you've done. How has your perception of innovation changed? Has it changed at all? And then how do you define it in terms of what
Yeah,
innovation looks like?
that's an interesting comment, Michael. I think you go back 5 years or 7 years. Innovation was something that everybody was talking about, and we created these innovation units. And I think that I know when I was at Herman, we talked a lot about innovation, but we wanted innovation to be a cultural aspect.
Right.
It wasn't a department. Everybody needed to be innovative. And, as long as you kind of know what your North Star is as an organization, I think you want it to be a cultural attribute of the organization, and not really a department. And
Mm.
so I think, what we see is just continuous technology and opportunities for innovation, whether it's in IT, which, I spend a lot of time at, but drug delivery, science, all these other care processes are going through a similar type of innovation model. Because one thing that I think the American healthcare system has gotten in its head now is there's no new money coming. There's rates are, usually Medicare is tapping that down. Commercial is really hard to go get that 7, 8, 9% that big health systems used to get. Now you're fighting, usually the entry salvo from the Blue Cross plan or whoever it is like a -5, and you're asking for 7 and you end up at 3, and you got expenses usually growing faster than what your managed care rates are increasing. And so you've got to innovate a margin on the income statement by doing things better, faster, cheaper. And IT plays a big part of that, no doubt.
I'm curious because you're sitting at a really interesting position now. Looking back, what's one maybe prediction about the industry that you made earlier in your career that has maybe interestingly enough not come to pass?
Um, Walmart. I was a big proponent in a strategy role that we needed to be prepared for Walmart to buy a Medicare Advantage plan, and that they were going to be vertically integrated, and they were going to dominate primary care in rural secondary markets across the United States.
Hmm.
But hey, at the same time, we also were preparing for the verticalization of United, Aetna. They kind of went the other way with CVS. And I think, to these large healthcare systems right now, there is a real tumultuous time around primary care. Are these big national brands going to emerge for primary care? What role then does the healthcare
Right.
system play? Or are healthcare systems going to seize the day and really deliver upon a consumer experience in their local markets? Because they have the local brand. And
Right.
are they going to be able to deliver a retail like experience for primary care? I'm frustrated at the rate of value-based care of these big healthcare systems. We see all these new entrants that are coming in trying to, organize doctors in these value-based contract agreements. And I just think the healthcare systems have a little bit kind of retrenched back to what I know, which is give me brains, give me hearts, give me bones, and neonatal babies. And I hate to say that, I see a lot of retrenchment back to the fee for service part of the business, but that's what we know as healthcare systems. But we've got to be better than that.
Hmm.
Got to be better than that.
You brought up some interesting points, and this can go in a few different directions. But how have you navigated situations where fundamentally you know that technological innovations have clashed with traditional healthcare models, and what's been the learning, from that experience, and how are you applying that into what you're doing today?
Oh wow, I, it's a hard question to answer, Michael. I mean, people write books on that question. I my view of that is very pragmatic and very practical, and it's the rate of which you can implement and learn.
Hmm.
We all talk about fail fast and crawl, walk, run, but institutionally, do organizations adopt a mindset of innovate fast and learn from it? And we all talk about, oh, we're going to celebrate our failures, but really everybody hates failures. It's just universal. But you got to get out there and you got to try, and sometimes you got to recognize that stuff just doesn't work. I remember back at Hermann, we tried at-home primary care for pediatric patients. We did this little venture with this company out of Dallas, and we were doing it up in the Woodlands, which was one of our best set of zip codes, and it failed
Uh-huh.
miserably. But I look now and I see business models of people going in the home and making big businesses that get acquired by even bigger businesses. So
Hmm.
I think that, once you try something, just because it failed, you got to back away from that and really understand why it failed, and maybe how you need to reposition or repackage and try yet again.
Hmm.
It's really the
Interesting.
grind, man. I think innovation is a grind.
It is.
The technology is easier than changing the machine. And when I say the machine, I'm talking about the people and the processes that have been out there, for years. This is the way we do it. And the technology is allowing these new capabilities and these new processes, but that change management aspect inside of organizations to take what might be successful in a pilot and scale across the organization. I think we are under investing in change management.
Yeah, we share the same sentiment. I've seen that across the board. And so this is a nice springboard into the next sort of question, because then what strategy have you seen or even been a part of that you believe has made the most profound difference in the delivery of care in the patient experience? You mentioned consumer experience and bringing it to people and having it be local, but what's made the most profound difference?
You know, I think we've scratched the surface so far. And I think that our industry, and by the way, after Herman went to Cerner, Cerner, which then became Oracle, left when the Oracle machine came in, then started our own company, Waypoint, with a couple of other trusted colleagues. So actually, my career, Michael, if you wanted to, it started on the vendor world with IBM. I
Yeah.
was a young marketing rep and sent to Louisiana and said, "Hey, you've got all the hospitals north of Baton Rouge. That's your territory. Good luck, kid." And that was my introduction to the industry in Shreveport, Dallas, Houston. Then recruited by my client, Memorial Hermann, to be the CIO. So I leave from vendor world over to the provider world 20 years, and then to Cerner for 3.5, which was a great run. Really sad to see kind of what all happened and how that thing ended up, but that's a whole nother.
Yeah, that's another episode.
That actually ought to be a Harvard Business Review article about what happened to Cerner, but I'll get off that soapbox.
Mhm.
But kind of back to your point, um, what I've seen is we got after a lot of low hanging fruit in the consumer experience by what I'll call point solutions.
Mhm.
And if you roll back a couple of years, portals were really growing and emerging. Then you saw the advent of texting. I think
Right.
texting had a step improvement. You've seen now some of this conversational voice come in. You see the CRMs really trying to organize around this. But I think that we've got too many point solutions, and
Mm.
what we're not thinking about is the patient experience that flows through all of those different point solutions. And between the multiple portals that a patient may have that's visiting a healthcare system, with independent doctors, with joint ventured surgery centers that may be running on a different EMR. Heaven forbid they go to a post acute provider and there's a different set of systems, and you kind of get the point. So I think what we've got to start to think about now is how we curate these experiences for patients, pre-visit, post-visit, and what I'll call in between visits. And
So you've been
I think, Michael, that's where we got to really be focusing on.
you've been sort of this voice, this strong voice that's corralling people around this concept of care orchestration. Is that sort of what you've just described, or is there more to care orchestration?
Well, I think it's the base. So if you think about the four walls of the institution, the EMR does a job of workflow management. So we all built care sets, the CHF care set, the cabbage care set, and that care set inside of the institution executed a certain workflow for the patient and
Right.
for the staff, right? So we're going to deliver these drugs, we're going to try to ambulate the patient, we're going to get them up, we're going to do this, we're going to hopefully discharge them in 3.4 days, let's say. um, my point is, what happens outside of that experience? And if you think about the players that are now involved in these networks, they're not all in one EMR. We may all think that they're going to all be in the one from Wisconsin, but reality, if you really do a map of what makes up your network, there's lots of different computer systems, lots of different EMRs. And what I'm talking about in care orchestration is the ability, not only at a health system, but I think there's a lot of health system partners that surround that big not for profit that we need to be thinking about in our ecosystem. So it's the ability to know what we're going to do with, I'll just use a simple example, a CHF patient post discharge.
Right.
And I hate to say it, but there's probably a pathway for value-based care patients, because oftentimes the the system, I'll just call it the system, has care managers that are going to follow the value-based care patients, but the commercial patients or the Medicare patients that may not be in an ACO or a value-based care. They may go down a slightly different pathway. Medicaid patients may go down yet a different pathway with a different set of care managers, different motivation by those. And care orchestration says, look, we're going to take this trigger event, this post discharge, and we're going to execute a series of flows. We're going to put the patient on a workflow engine where we can engage them with a modality that is aligned to their interest and aligned to that particular intersection point. So what I mean by that, a text may be the appropriate thing. A form may be the appropriate thing. Discharging an avatar, you've seen all these new AI-based avatars that are pretty cool. Discharging an avatar may be the right thing. But really, how do we orchestrate that care flow? Not with people. I've seen tons of these startups and healthcare systems talking about, oh, our care managers, we can't get to everybody. We can't call everybody on the phone. Yeah, you can't. There's no way.
Yeah, yeah.
You'll never be able to call everybody on the phone. So how do you get the technology layer to execute the task and then have your people working the exceptions?
Mm.
That's what I'm really driving and thinking about, because I think the care manager or the navigator, we use lots of different words in healthcare to describe them, pre-visit or even post-visit. I think they are a tool to be orchestrated, just like the technology is.
And and how much change management do you think is actually needed in order to get someone to the point of wanting to embrace this care orchestration concept and execute on it? Because you mentioned that oftentimes it's really about the human side of change that's most difficult. It's not necessarily the technological component. Where do you think that plays into the care orchestration aspect of
Yeah.
things?
Very close, who's become a very close friend, the CMIO that we had recruited into Memorial Hermann, a guy named Bob Murphy, Dr. Robert Murphy. Bob now actually is at the University of Texas, by the way, here in Houston, teaches a class called Change Management. It's a
Okay.
PhD informatics class, and he teaches it called Change Management. He had a saying, and he said, "You never do something to a doctor, you do it with a doctor."
Mm.
And I think there's a lot of wisdom in that. Never do something to a doctor, you do it with a doctor. And think about the sessions that we've had with a whiteboard. And we've got the clinicians around the room, and somebody's up there drawing. This is our pathway. This is what we're going to do pre-visit, or this is what we're going to do post-visit. And we draw it on a whiteboard. And, we got all these if-thens and all these arrows, and then we publish that in Visio or Lucid Charts or something like that. And we get a binder of them, and this is our playbook, right? And then we all leave the conference room, and what happens, right? Everybody kind of goes back to doing it the way they've been doing it with
Right.
these care flows in this binder. I think that we're seeing software now replace that whiteboard. And to answer your question, I think it's about the team managing, I'll call it the CareOps. So think back 10 years ago, maybe 12, 15, around development. We traditionally had kind of a waterfall development model. And then we all went to DevOps schools, the EPAMs
Yeah.
of the world, and all these consulting companies came in, and, we figured out new ways of doing software development. I think we're on the verge of having to do that. And I think that's where the differentiated opportunity comes with health providers is, can you build the equivalent CareOps organization? So IT is not doing this to the clinicians. The clinicians
Mm.
are sitting around the room. It's not a whiteboard anymore. It's now software that's executing the care operations. And the clinicians, and there's a handful of them that'll be able to build in these no code solutions. One that I see and watch and work with is actually coming from Europe, got a good footprint in the US, called AWell,
Mm.
AELL, awellhealth.com. They're also really proponents behind this CareOps organizational model. CareOps org, as industry kind of development. And
Interesting.
if you think about that, just think about that. The way we would design code, you'd have product managers, you'd have developers, you'd have database, and people would sit around the room and we would go through sprints and we would deploy the code. I think that's how we're going to approach the change management aspects, by engaging the clinical leadership around the table, not on a whiteboard, but designing in these new no code software solutions. And we're going to then come out with, okay, here's what we're going to do post discharge for CHF patients. We're going to have 3 pathways, boop, boop, boop. And on pathway 1, we're going to do this. And if the patient responds positively, we're going down this pathway. If they say they're having trouble, we're going to put them on a list and a care manager is going to call them. Okay, the second pathway, this is what we're going to do. This third pathway, we're going to turf all those patients over to the community care management resources, and they're going to have accountability for them. And this is their action that they're going to do. And we're going to automate this care pathway, this care flow. I'll call it a care flow. We're going to automate this care flow. We're going to build it. We're going to test it. Then we're going to implement it. And we're going to watch it run. We're going to, watch the dashboard. We're going to see patients move through, and then we're going to measure the heck out of it. We're going to refine it, and it's going to become ultimately our platform for executing these types of care flows. And we're going to be able to measure at a discrete level, because we're going to instrument these care flows. We're going to instrument them with measurements. So we'll know, and my guess is we'll have some kind of AI layer that sits on top of that, and we'll say, how many CHF patients dropped off after the 3rd form? And, learn from that. We're going to iterate on it. And it's not going to be IT, because if IT's doing this, man, we're in trouble. It's got to be those white coat people. It's got to be the nurses, the clinical liaisons, the nurse navigators. And I think it's going to bring a lot of excitement for them.
You
Yeah.
just unpacked so much in that. And I just want to sort of take a step back. I'd say the aha moment for me personally was when you said, we're not doing it to the doctor. The 2 millimeter shift is we're doing it with the doctor. We're not doing it for them. We're doing it with them. And I think the combination of that is quite profound. So kudos to your colleague and CMIO who's been sort of preaching that, because it's a major difference. And something else that kind of came to my mind is you mentioned about measuring the heck out of things. I think we're in a world now where there's so much data. How do you know what to measure? Like, what are the right things to measure? And when you were sort of sitting in that seat, what was your sleep well at night metric where you could look at, 1 or 2 metrics and say, okay, this is good. What was that?
Oh, Michael, I think that's a question. There's lots of levels to answer that question. At
Yeah.
the highest level of an organization, we called those big dots. We had big dots. We had used a term from some quality program, and you had your global measures. But as you move down the organization, I think each layer of management has to have their own set of KPIs
Yeah.
and measures. So a cascading set. What I'm describing here is in a care flow, post-discharge CHF follow-up. What are the key measurement points that we need to instrument into that care flow so that we as a CHF post-discharge follow-up team, and I'm using this as an example, think of this as annual wellness visit. Think about this diabetes screening. Think about this colonoscopy. Think about this nutritional counseling. Think about this mental health screening services. Think of this a referral. I mean, healthcare is a set of processes. We are the ultimate workflow industry. And if you really think about it, outside of the 4 walls, we really don't have a workflow tool that we use. So what I'm describing here is micro measurements at the care flow level, and then being able to watch and see how patients are navigating and moving through these multi-channels. Because when you live in a world of point solutions, you have no real ability to see how you're working across all the point solutions. Each of those vendors has kind of, I can tell
Yeah.
you how many texts I sent, I can tell you how many conversations I had, I can tell you how many people clicked on this button in the portal. But what we've got to do is, instead of look at this as point, we got to look at this horizontal as kind of the experience level.
Interesting. I'm curious, how come no one's like really looked at it from that lens? Or do you think people have tried and just not gotten it right?
Um, I think one, there's been a little bit of a lack of software. I know when we were at Cerner, we tried doing this with a big CRM. Um, I was in the Healthy Intent business unit, which was a great, I think, one of the best assets of Cerner. And I am super stoked about Oracle as they've kind of wrapped their arms around this now and kind of redefined it. Um, but we had all of these big populations. Healthy Intent was the pop health platform that set
Hmm.
up multiple EMRs, Millennium being the EMR that Epic's just killing them on. Um, but you had these numerator and denominators, and we had all this math and logic that went into managing the numerators and the denominators. And by and large, we had tried to hook up one of these big CRMs to it
Hmm.
and have the CRM drive activities to those populations, to the numerators, to the patients that needed a screening or a colonoscopy or this or that. And I think our experience was that the CRM platforms, first they usually came with $1 million systems integration fee.
Yeah,
It
not
just
cheap.
it just usually seemed to be about $1 million. And there was a lot of emailing, because that's kind of the origin of where they came from, was consumer patient acquisition or customer acquisition, a lot of emailing. And we had some success, but I think that's what we really was kind of our toe in the water,
Yeah.
and what we're really working on and what we're excited about, and we're doing some work, like I said, with this new company, Awell, is taking this software and sitting with clinicians and now building those care plans using the point solutions that they have. So if, let's say, they have Artera, which I think is one of the best texting platforms around, and we're going to use that text platform to deliver that post CHF message. Boom, send it to the API, send it.
Hmm.
Then we're going to put a portal message into MyChart. Okay, there's an API. Boom, put a portal message into MyChart. And so we're not creating new endpoints for the consumer. Typically, what we're doing is using the existing endpoints. We may bring a couple of new ones. There's, I think of this whole area of conversational voice is a new area. It's replacing kind of the IVR stuff with now
Yeah.
intuitive agents that are having a conversation with you, kind of much like what you and I are. And sometimes people don't even know that it's software, but
Yeah.
it's human. Um, and so being able to leverage those point solutions that we have to execute that care flow.
Hmm. Interesting. You mentioned AI earlier, and with AI and machine learning becoming more prevalent in healthcare decisions, how do you foresee the industry addressing maybe the ethical implications of tech-driven healthcare?
Man, talk about an interesting topic. Um, Michael, I don't know that I'm real qualified to opine on that, but I'll give a couple of views because I think we're early
Yeah.
in how we're doing that. There's a lot of work to make sure that our models are not discriminating. Um, and I think that, first of all, let me back up for a moment. I think that this notion of AI and machine learning is not that new to healthcare. I think we've been doing things in this industry. We just didn't really have the umbrella term of AI till Chat GPT got out.
Yeah.
But I think what we're starting to see now is it's permeating many different levels in the organization. And if people are creating departments of AI, I think they're going to go the same pathway that innovation did when we created departments of innovation. I think you got to ingrain it in the organization. One, I think a lot of the software vendors are bringing AI into their solutions.
Mhm.
Whether you're using ServiceNow, whether you're using CrowdStrike, RIP, what happened with those guys this week, um, whether you're using Epic, whether you're using AWell, whether you're using any of these, software solutions, they're embedding, AI into those solutions. And I think you got to have a portfolio of plays. You got to know what you're
Yeah,
doing, where you're doing, and what's working and what's not.
well said. You've done so much in your career, and it's lots of milestones. Is what's maybe one goal or aspiration in your professional life that you're still trying to achieve?
You know, it's I've always worked for the man. I worked for IBM, I worked for Memorial Hermann, and I worked for Cerner. So I've worked for three, I think, great large companies. Now at Waypoint, I've got two partners, Lisa McDermott and Doug Rogers, folks that I've known for a long time, and myself. So the three of us, and we're building our own company. And I think that is very interesting. It's very dynamic.
Yeah.
It is a eat what you kill kind of model. You kind of know that, Michael. So it just adds a degree of freedom, but it also adds a degree of, oh shit, what are we going to do? How are we? Well, the lawyer's $550 an hour, and we don't have
Yeah.
an in-house counsel. It made me appreciate many of the colleagues that I've had along the way in these larger organizations. But building our company right now is what I would say.
Cool. Well, how can we follow you and the work that you and the team are doing? Give us a little bit of a commercial snapshot before I wrap.
Yeah, well, one thing I would say is get on careops.org and read about that. We do a lot of podcasts. We do a lot of work with CareOps. Follow us on LinkedIn. We do a lot of surveys. We're really big into talking to people. And hit me up, David.Bradshaw at waypointhcs.org. I mean, .com, sorry, .com. I'd love to have a conversation.
Amazing. David, it's been really nice to chat with you. And for those that have tuned in, if you found this conversation to be particularly enlightening, and I have to say that there's been a lot of golden nuggets that I've extracted from this discussion, would you mind commenting on it, sharing it, engaging with it, letting us know what stood out to you? What are you going to take action on? Because at the end of the day, innovation is about action. It's not about sitting back and drawing things on a whiteboard and talking, thinking, and meeting. No, it's about doing. So if you found it interesting, please comment, let us know what you think. And David, look forward to our next chat. See you
All right,
soon.
right on, Michael.